So, Joel Dunning here with CTSNet, and I'm so delighted to be here with an absolute star of minimally invasive surgery. Joe Zacharias, thank you so much for joining on. You're a fantastic surgeon in Blackpool. You've been doing minimally invasive surgery for over 15 years. And the reason we brought you on the podcast is we've just profiled your absolutely fabulous article in The Lancet, one of the highest impact journals we've got. And the title of it was Lifetime Management of Heart Valve Disease. Treat it early, treat it right, treat it first time. And so we'd love to hear from the horse's mouth, from the author. You had an amazing group of co-authors on this, and I think it's got some really, really powerful messages. So maybe tell us a bit about how this article came to be and tell us about the powerful messages in it.
Thanks, Joel. It's a huge pleasure to be on this podcast of yours, and amazing what you're doing with it. So thank you for profiling this comment that we got published in The Lancet. And it all started off with a presentation by Torsten Dunst and his team regarding registry data from TAVI results not seeming to match the results from randomized trials. And unfortunately, he couldn't get that article published in any of the cardiology journals on the basis that it was a registry and it was not randomized, etc. So he kind of was trying to get a paper published looking at basically what the differences are between randomized trials, registry data, why there's differences. And we started talking about this, and then we kind of moved that into a kind of mechanistic field where we started talking about heart valve disease, like mechanical valve problems, and the fact that, quite often we see patients too late in the disease process. As you know, I do a lot of thoracic surgery, and I've been quite sort of marked by all the work that's gone on in oncology, and how when I started my career, lung cancer survival was 4%, and now with lung cancer screening and teamwork and MDT working, things have improved. So we started talking about how cardiac surgery and cardiology could maybe start to work like oncology and try and work better in not just small teams, but bigger networks. And then we came across two giants. One is Maurice Enrique Serrano, and of course, Julian Dreyfus, who had done a lot of work on TriScore. And we had a Zoom call, and we were talking about how we could bring it all together to write a paper about this idea. And I must say, Maurice's idea was to just focus it on a few points. And of course, his lifetime work has been the fact that heart valve disease is, number one, picked up too late, and number two, referred too late. And his kind of passion is asymptomatic heart valve surgery. So we kind of went on to that, and one of our fears was that asymptomatic valve surgery, when picked and sent early, if sent to transcatheter sort of procedures which do not have long-term robust data, we were worried that, number one, it may not be good for patients. Number two, it might be expensive for health systems which are already creaking under costs. And then it came about that maybe we should look at an article that covers, number one, get patients early, but number two, get the right treatment at the right time. So there's a lot of evidence with certainly things like mitral repair, tricuspid repair, Ross procedures, that you can actually offer curative operations with heart surgery. Nearly all prosthetic valves come with, unfortunately, a price, because prosthetic valves have a prosthetic valve failure rate, whether it's mechanical, whether it's tissue. And so the article was kind of trying to focus on maybe we should find curative options very early. And at the moment, the only curative options are valve repairs, Ross procedure. The newer mechanical valves hold some hope, but we haven't seen it long enough. But we are hoping that that would also make a improvement in long-term survival. And the final sort of message from the paper was that really it's a collaborative approach. We wanted to kind of work on that. We did have a whole paragraph on game theory and, not having a zero-sum attitude between cardiology and cardiac surgery, but really looking at it as a positive sum relationship, that when we get better, they get better, they get better, we can get even better. And together we provide the patient the best sort of long-term results. Unfortunately, with constraints on wording, all of that got dropped, but we still feel there's enough work for everybody everywhere. And it's just about getting the right patient to the right treatment at the right time, and hence the sort of title about it. But we were quite pleased that it was accepted, and we accepted that some of the messages would be dropped. Our key message is that it's a team effort. We work together with cardiology, hence the stress on networks, because sometimes you cannot offer ROS procedures in every hospital. You can offer things like endoscopic mitral surgery, mitral repair in every hospital. And Maurice Enrique Serrano has always been a big fan that in asymptomatic disease, patients may need to travel further afield to get to the right treatment. And his view when he was head of Mayo Clinic was that it was worthwhile for those patients to travel all the way to Mayo Clinic to have Hatzel-Schaft do their mitral repair, because they got a 20-year sort of freedom from any other intervention as long as he had looked at it, and probably further. And that was the kind of message we tried to distill.
So, I mean, one of the things that came out that I was really found quite remarkable was your comment that if picked up very early, maybe in asymptomatic, that perhaps the mortality, even interventional mortality, was not that dissimilar to transcatheter approaches. And I guess that sounds to your point of it being the real world data showing that actually, they're about the same. Maybe you could say a little bit more about how actually maybe even interventional mortalities are the same between these two techniques in the early patients.
Yeah, so I think we also had a paragraph about this thing called perceived risk, because
Mm.
perceived risk is very different to actual risk. So actual risk is the real risk that any procedure has from any intervention has. And all the randomized trials, whether it's PCI versus CABG, whether it's TAVR versus AVR, whether it's MitraClip versus mitral surgery, it's nearly always just a few point difference, and quite often it's more or less the same. It's kind of 1% or maximum 2%, except in the high risk TAVI trials where we knew that surgery was going to be much higher risk. But once you come into the low risk category and the asymptomatic patients, the risks are below 1%. I mean, we've all come across the large series from Cleveland Clinic with robotic mitral surgery showing 0% mortality at 1,000 patients. I mean, these are achievable in the real world in highly specialized centers. Every time you consent a patient, they nearly always think their mortality is 50%. How much ever you try and explain to them that it's kind of less than 1%, in their own perception, it's just much riskier than it actually is on paper. And we make the point that perceived risk may be one of the reasons why both patients and some cardiologists don't refer early. And one of the things that we did as part of a group of endoscopic surgeons is 7 of us put all our asymptomatic patients together, and we have about just under 200 asymptomatic mitral patients over the last sort of 5 years. And we have a 0% mortality. So when you come that early and fit, the mortality risks are very low. And this seems to be difficult to get into what we call the general cardiologist's acceptance that it needs to be sent early. And of course patients as well, because quite often patients will choose a MitraClip thinking it's less risky, but in the long run, probably a mitral repair done by an expert surgeon and an expert center will carry lower risks at 3, 5, and 10 years. But how we communicate that is probably the challenge cardiac surgery has faced throughout its history.
Yeah, I've always found it absolutely crazy that we talk endlessly to the patient about the mortality over the next 5 days, and we don't talk about the mortality for this patient over the next 10 years or the 20 years. Surely we should be talking to them saying, well, let's look at your 20-year lifespan and how likely you are to get to 80, with these two paths. I think we are far too focused, aren't we? And perhaps it was the registries and the surgeon published mortality that got us completely obsessed with this. But were you also saying that in real world, actually, MitraClip mortalities, in these groups are actually a little bit more morbid than we might think from the trials as well? That was another thing that you were mentioning. Is that right?
Yeah, no, you're right. And I think one of the things we need to learn is from what you and lung cancer specialists have done really well, because, lung cancer networks across UK are not just measured on 30-day mortality, but you'll have your 1 year and your 5-year survival. And, personally, between you and me, I wish we had a TNM score equivalent for cardiology and cardiac surgery. I wish we could say that, if your ventricle's good, your age is low, your symptoms as between 0 and 1, surgery is definitely going to be the better long-term outlook. But once you get to NYHA4, you know, even the best surgeons and the best units cannot get long-term results, because once your ventricles suffered and you've already into atrial fibrillation and you have other signs of failure, maybe then transcatheter approaches might be less risky and less also expensive, because sometimes you operate on NYHA4 patients and they really end up on ITU for long periods, costing both the unit and the society a lot more. So there is some amount of learning that cardiology needs to take and cardiac surgery need to take from the benefit from the advances in oncology, and how oncology has really managed to channel the right patients to the right specialities.
And one other striking part of your paper is you quoted that perhaps only 25% that do reach international guidelines that indicate cardiac mitral repair or an intervention is indicated actually get referred. And that's not in the developing world, that's in America and Europe. So, I mean, maybe say a few words about that and, where are the holdups?
Yeah, so now this is something that surprised us, because originally it was done in US. I think it was the Olmsted County audit, and then it was sort of redone in Oxford, and it was Oxvalve data that we used. So yes, unfortunately, a lot of patients, number one, think it's just aging. So, heart valve disease is a very insidious thing that comes on very slowly. You kind of find you're a little bit more tired, a little bit more short of breath. And the number of times I see people who are 55 in my clinic saying, well, I just thought I was getting old. And you just go, well, you're just 55, you're not old. Especially as I get older, I keep saying, no, you're not old. But this is one of the problems, that patients just put it down to themselves and not necessarily approach doctors. The other problem is, of course, as you know, GPs are under so much pressure that listening to heart valves has really gone out of a routine general practitioner examination. And there are very nice opportunities that are being sort of set up with AI and new sort of devices, but still listening to heart valves is going to be the easiest way to pick up murmurs. And once you pick up murmurs, patients get referred. The other problem is, once you pick up murmurs and get to cardiology, sometimes there are some what we call conservative cardiologists who still believe that, heart failure is just something that's going to happen 20 years from now, and that you can just treat them and keep them on diuretics and it'll probably go away. And there's this usual thing that, oh, you can grow out of mitral valve prolapse. These are things that are sort of myths that were probably spread in the 1970s and 80s, when heart surgery had a 25% mortality. But really now, with UK-wide valve mortality less than 1% in sort of young, fit, Euroscore low patients, I think it probably is dependent on cardiac surgeons and probably cardiologists to sort of provide that message that, get people early. But of course, the final thing is how to deal with the NHS waiting lists. We're all working really under a lot of constraints and cost constraints, and that's why we tried to bring in an angle that, it might be cost effective to treat them early and treat them right. Because when people start to get worried about budgets and costs, sometimes people try to think cardiac surgery is an expensive sort of intervention. But as I always say, one of the reasons I went into cardiac surgery is an extremely good talk that I heard from Albert Starr, where he said cardiac surgery is the most cost-effective specialty in the history of medicine. Because, when we fix left mainstem, if we fix aortic stenosis, if we fix mitral regurg, we don't get days or weeks or months, we get years. Well, you see all the oncology trials showing data with weeks and months and justifying costs of very expensive drugs. But cardiac surgery does that with years. So really, there's a lot of probably work we have to do to make people more aware that cardiac surgery is cost effective and needs to be offered early.
Yeah, well, Absolutely fantastic to see your leadership in this field. And because you're such an experienced and wonderful minimally invasive surgeon, I can't help by asking you, where should we go in the next 5 years in the UK, in Europe, and internationally? Certainly, Enoch Okoa from our unit, who's president, says he really wants to push minimally invasive cardiac surgery. We've got to really sort of, make this routine rather than exceptional. So, if we talked in the year 2030, what would you like to see the landscape of cardiac surgery being internationally?
Yeah, thanks, Joel. I hope you will invite me in 2030 to have another chat. But I think so. I have a slight bugbear with the term minimally invasive. So, minimally invasive is just too broad a term. And if you use minimally invasive as a title, even TAVI, MitraClip, every cardiology intervention is also minimally invasive. And to be fair, they're more minimally invasive than what we do. And so you can see websites which say centers of excellence in minimally invasive, and then we look at them, actually they're talking about TAVI or MitraClip, and it rightly so because it is a minimally invasive intervention. Hence, the push to come up with a term that surgeons can own and surgeons can control, and that is why we kind of push this term called endoscopic. Now, you've seen it in thoracic surgery. I'm sure when you were training and I was training, there was a whole bunch of surgeons who went from thoracotomy to mini thoracotomy. And they'd make a big issue about how wonderful the mini thoracotomy was while stretching the ribs and reducing the skin incision and struggling to get to see what they were doing. And I feel minimally invasive direct vision cardiac surgery is just that. It's equivalent to the Cocker incision for the gallbladder. But really, a specialty only grows and matures and takes off when an endoscope comes in, as you know, with thoracic surgery. And unfortunately, cardiac surgeons have just been very resistant to it. Now, you can use a robotic endoscope or a 3D endoscope or a 2D endoscope, but the moment you put in an endoscope, and once you start looking up at the screen, two things happen. One, you get better because everybody can look at what you're doing and you have to get better because there is that element of sort of openness and transparency with a massive screen that everyone can look at. And number two, your trainees get better, and quite often they get better than you because they're learning from your mistakes, they learn quicker, they sort of see more of the anatomy than through a small hole. Endoscopic cardiac surgery is where I see the future. It might take a bit of time. It might take some amount of investment, which at the moment is lacking in cardiac surgery because, we make a point in one of our articles that 97.4% of funding from British Heart Foundation goes just purely to cardiology. So it's just completely an unequal playing field. But I think the tide is changing. People are beginning to realize that this has a future. And I hope more and more patients will be offered an endoscopic approach, whether it's robotic or non-robotic. I think at the moment, with the financial pressures, robotic may be limited, but I think there is a role for that as well in some centers which already have robots. But an endoscope is the kind of middle way. One of the things I try to tell a lot of people is that we are often stuck in the zero-sum game where if you do one, you can't do the other. If it's which one's going to win, which one. But if you take, we should look more like market shares and market share. And at the moment, stenotomy is probably 96 or 98% in the UK. And we really need to make inroads. And I would hope at some stage we have 20% stenotomy, maybe 40 to 50% endoscopic, and another 20 to 30% robotic. But whether that'll happen in 2030, I'm not sure. I hope so. But I've been very jealous of you thoracic surgeons who've really run away with the endoscope, have gone away with the robot. You'll have really led. And because I do cardiac and thoracic, I kind of watch the thoracic surgeons not necessarily ask for randomized trial evidence, not necessarily ask for, level A evidence before they make a move. And you've gone from 3 ports to 2 ports to 1 port to, I don't know what's next, maybe subxiphoid. But cardiac surgery, unfortunately, has just been very slow to make that move. But one of the reasons I'm very optimistic is because of something called endoscopic vein harvesting. Well, that was the first thing we started in Blackpool in 2007. Today, it's standard of care. Everybody is being offered endoscopic vein harvesting. I don't know if it's reached Middlesbrough yet, but certainly in most of the northern, Blackpool, Manchester, Liverpool, certainly a lot of the centers down in London, nobody would consider doing open vein harvesting. And I remember sitting in rooms at that time and people wanting to push for the Mayo hook and bridging and open, but the endoscope really has taken a huge role there. So I hope it does in other specialties, other areas of cardiac surgery as well.
Great. Well, thank you so much for this wonderful podcast chat. Thank you for that amazing Lancet paper, which I think really is genuinely important with your co-authors. And also I look forward hopefully to seeing some of your videos on CTSNet. You're a very enthusiastic member of the Endoscopic Cardiovascular Surgeons Club. I think the meeting is September the 4th. Is that right?
Yeah, it's 4th to 6th. Yeah, I hope you can make it, Joel. It'll be lovely to see you there. We can teach us something from thoracic surgery.
And great. Well, thank you so much for joining. And from everyone at CTSNet, thank you very much for joining us tonight.
Pleasure to be on, Joel. Thanks a lot.